Should we shift all patients with HFrEF who are on ACE inhibitors to ARNI? And when do we switch? Should we wait till they become unstable? The point here is, are your heart failure patients really stable? That is a question we need to ask ourselves. When we know that the patients are not complying to medicines or the physicians are not giving the guideline directed medical treatment, there is a high chance that your heart failure patients could decline into hospitalizations for heart failure. They could have index again and again admissions for heart failure. So we should be very, very clear that what are the molecules we are going to start them on. Now, only 20% of stable patients, that means there are no prior heart failure hospitalization in Paradigm HF trial, had a primary event. 17% died during the course of the trial. Of the stable patients who experienced a primary event, death preceded the heart failure hospitalization in 51% of the patients. 60% of these deaths were sudden cardiac deaths. This is very important to understand. So the concept of stable heart failure does not exist, my dear friends. And ARNI should be started as early as possible for your patients. Convert them immediately if they are on a regular ARP or an ACE inhibitor, so that we don't wait till the deterioration occurs, because that deterioration may not be there, it just could present as an event of sudden cardiac death. Now, when you look at the 2022 AHA, the ACC, the Heart Failure Society guidelines for management of heart failure, the 1A recommendation is that in patients with heart failure with reduced ejection fraction and NYHA class 2 or 3 symptoms, the use of ARNI is recommended to reduce the morbidity and mortality. Also, 1A recommendation in patients with previous or current symptoms of chronic heart failure with reduced ejection fraction, the use of ACE inhibitors is beneficial to reduce the morbidity and mortality when the use of ARNI is not feasible. So, in patients with previous or current symptoms of chronic heart failure with reduced ejection fraction who are intolerant to ACE inhibitors because of cough or angioedema, and when the use of ARNI is not feasible, the use of ARB is recommended to reduce morbidity and mortality. So, only if there is severe contraindication for the use of ARNI, then only you should not use ARNI. Otherwise, in all your patients, which will come to around 98 to 99% of your patient group with heart failure, please do use ARNI. There is no option available.